So welcome, everybody. My name is Karen DeRuo. I'm the Director of Support Services at Alzheimer Group. Alzheimer Group is a charitable organization that supports families and individuals living with dementia. We provide therapeutic activities, counseling, and support groups for people living with dementia and caregivers, as well as courses, workshops, and webinars for professionals and families. Our education initiatives are made possible by the generous support of the Lasner Learning Center and the Lindsay Memorial Foundation. Today, we're very lucky to be joined by Dr. Howard Chertkow. Dr. Chertkow is a cognitive neurologist at the Baycrest Health Sciences Center. He's a senior scientist and chair in cognitive neurology and innovation at the Baycrest Academy for Research and Education. He's a professor in the Department of Medicine, Neurology at University of Toronto. And at Baycrest, he's also the director of the new Bank Family Clinical Trials Research Unit and the Kimel Family Center for Brain Health. His major areas of research interest include early diagnosis of Alzheimer's disease and therapy of dementia using neuromodulation approaches such as transcranial direct current stimulation. Dr. Chertkow is scientific director for the Canadian Consortium on Neurodegeneration and Aging, the CCNA, a national organization established by the Canadian government via CIHR and partners. In addition, Dr. Chertkow worked for the Jewish General Hospital for 30 years, so he's had a long-standing relationship with us at AGI and has been doing these yearly conferences for us for many years. He moved to Toronto in 2018, which was a big loss for the Montreal community, but we're lucky to have him back over Zoom once a year. So before we start the webinar, I just want to let you know the chat function in the webinar doesn't work. I don't know why Zoom leaves it there. So if you have any questions, don't put them in the chat. You can put them in the Q&A, okay? And we'll monitor the Q&A throughout. And at the end, we'll have a question period where we will read out your questions, okay? Now, I can't promise we'll get to every single question. We'll make sure that we're reading out the questions that are more specific to the topic. If you have a question that's not read out today, I encourage you to call the office sometime this week or next week and make an appointment to speak with a counselor, okay? So I'm going to give the floor to Dr. Chertkow, and I'm going to turn off my camera so that everybody can see you well.
Okay. Thank you, Karen. Thank you, Molly, and thank you for inviting me to talk to the Alzheimer's group. I've been a big supporter for many years. So my plan is to show slides and talk for about 45 minutes, and then we'll have a question period. And somewhere in the middle, I'll be putting in a plug for our own research because we continue to run a therapy research lab based out of the Jewish General Hospital. Actually, our lab is over at Cavendish Mall in the CLSC, and we're doing electrical brain stimulation. So I'll mention it briefly in the middle of my talk. So I'm going to go to share now and share my slides. So here we go. Oops. Let's try to go back to the beginning. We'll try again. Okay, there we are. So I'm going to be talking about new treatments and prevention strategies for Alzheimer's disease and dementia. And presenters always are supposed to show their conflict of interest. I'm talking about therapy, so you should know I run a large clinical trial center at Baycrest. I've worked with basically all the different pharma, but I don't get paid by them. I have no stock or equity interests, and I'm very interested in new developments for treatment, and I'll be talking about these. And my salary is supported by Baycrest and University of Toronto, and I have grant support from a lot of these funding agencies. So I like to start with this, one of my favorite slides. This is a man who lived in Haifa, Israel, and at one point he was the oldest man in the world And he was famous for celebrating his bar mitzvah when he turned 113 because he'd missed his bar mitzvah because of World War One. And he was still at age 113. He was active. He danced at his bar mitzvah. He was cognitively vibrant. His memory was good. And he was very social. And he was that's sort of the life that we all want everybody to live, to remain active in body and healthy in mind and able to function up to a long age. So, in contrast to this, we know that dementia is going up. And these are statistics worldwide. The number of people with worldwide in the millions. It's going to be 140 million people. Why is it going up? Because the world is aging. And Canada's population is aging fast. And so the number of people with dementia are getting more and more. They have diagnosis of dementia where they have trouble functioning, and diagnosis of what we call mild cognitive impairment where they are in the early stages of memory loss but continue to function on a day-to-day basis. So dementia is memory loss happening with aging. It gets worse. It impairs other cognitive functions along with memory. And we call it dementia when it gets to the point where it impairs day-to-day function. And there are multiple things wrong with the brain in dementia. In about half the cases, the main cause is Alzheimer's disease with plaques and tangles, and it's generally a downhill course. So, what we're going to be talking about in this talk is in the first part, we're going to talk about the new treatments, particularly anti-amyloid treatments for Alzheimer's disease, but we will mention other therapies and talk about in the second part what you can do to maximize the chance your brain will stay in top shape until the day you die. Um, we're going to talk about genetics, the things that you can't change, illnesses, what you can mitigate, and lifestyle changes, what you can do a lot about to change your lifestyle to decrease your risk, and the mysterious ingredient, motivation for change. So we'll start with treatment and then we'll move on to prevention. So first, developing new therapies. Well, this is going to be the big decade for development of therapies to slow down or stop or modify Alzheimer's disease. We're already starting to see these appearing. Now, Alzheimer's, in my view, is a complex illness, and dementia is complex. There are multiple paths. And what we're talking about now is what we call misfolded toxic proteins, such as amyloid. These are the first drugs to get to the market, drugs that block amyloid and the other important protein called tau. But in many Alzheimer's patients, there's also a problem with inflammation in the brain. There are problems with lysosomes, synapses, the connections between brain cells, problems with calcium, little structures within each cell in your body called mitochondria. Those stop to work well. And things called oxidative stress with ROS, it stands for reactive oxygen species. These can damage the brain due to cosmic rays and changes in the atmosphere or exposure to pollution. So there are multiple things going on in the brain that result in dementia, memory loss, and Alzheimer's disease. So what we think is that in the future, the treatment of Alzheimer's may involve multiple medications working in a complementary fashion, or maybe targeting in one person, it's important to target the mitochondria. In another person, it's important to target the amyloid and so on. So it's not going to be probably a one size fits all, one medication does everything situation. So we have many drugs that we are trying in our clinical trials unit at Baycrest, and these are the sort of the mechanisms of the drugs. So it's many mechanisms, which is to say, we're going to see a lot of drugs appearing in the next 10 years, and it's too early to say which of them are going to be the best and which ones will need to be used in combination. What we have now is the set of drugs to remove amyloid. So these are immunotherapies. These are immune-mediated drugs which go after the amyloid in the brain, and these are the ones which are getting to the market first. Now, if you look inside the brain of someone with Alzheimer's disease, this cartoon, and this is a cartoon, shows the two main changes. This is a normal brain. We'd see the brain cells called neurons. These are the essential cells that carry all the energy and the communications. They make the brain function. In someone with Alzheimer's, we see between these cells a deposition of a protein called amyloid. These are called amyloid plaques. And within the cells, we see these little red things that aren't there normally called neurofibrillary tangles, and those are filled with a protein called tau. So tau and amyloid, these are the two proteins that we think are the most important in Alzheimer's. And these are the changes seen by Dr. Alzheimer when he looked in the brains of people dying with this disease over 100 years ago. So drugs available now are attacking the amyloid or attacking the plaque itself. But in the lab and in our research clinical trials center, we're also working on drugs that block the tangles. So these are two different approaches to getting rid of what we think are toxic proteins. Now, the effort to get rid of amyloid, the main protein in these plaques, has been going on for 25 years. And one of the ways we study how well the drug is working is using a PET scan. A PET scan, you inject water, which is slightly radioactive, and it tags the amyloid in someone's brain. So here's an individual studied at baseline in a clinical trial, and 1 year later, this individual was on placebo, and you see the amyloid that shows up as yellow or orange or red was there at the beginning of the trial, and 1 year later, it's still there and even a bit more. These are two doses of an anti-amyloid drug, and look at this higher dose. Here was lots of amyloid at the beginning, but after a year, most of the amyloid has disappeared. So this was a drug called aducanumab. It was released in the United States, but it isn't doing well enough marketing, and we're probably never going to see it in Canada, but it did get rid of most, but not all of the amyloid. So the two drugs that are now available in the United States are called lecanemab and donanemab, and both of them are immune drugs that bind to different aspects of amyloid or amyloid precursor and get rid of it. Lecanemab is Eisai and Biogen, donanemab is Lilly. And these are the studies that were done that proved that they work. These these approved amyloid targeting therapies, ATT, they're effective. They slow the progression of the disease in people with mild cognitive impairment or mild Alzheimer's dementia. And this has been shown that they get rid of the amyloid, the so-called lower the amyloid burden, and people who are on the drug have less cognitive and functional decline and a lower risk of going on to a more severe stage of dementia. So this is what I'm going to show in a couple of slides. Now notice there's no claim that people went back to being normal. When they got rid of the amyloid, it did not return people to having totally normal cognitive function. It didn't even, for most people, totally stop the disease. What it did was slow the progression. So we have to be realistic in what to expect from these medications. Safety, there were some adverse events, AEs, and we're going to talk about these in a later slide. Now, people say, which one is better? The trouble is, the two studies were big, but they were slightly different. In the lecanemab trial, people treated with lecanemab, their average age was 71. In the donanemab trial, it was 74. In lecanemab, it was mainly people with mild cognitive impairment, about two-thirds of the group. In the donanemab study, they were a bit more severe. 80% of the people actually had dementia. So you can't directly compare. There are different people in the studies. Both of them worked, but we can't compare directly to say one is necessarily better than the other. They targeted different stages in amyloid. This is a cartoon that shows the stages from what we call the amyloid precursor protein that's created in cells, which bind together in what we call monomers and dimers. These float around in the spinal fluid and blood. And then when they bind into bigger clumps called oligomers and protofibrils, they become insoluble and they get deposited in the brain, eventually ending up as plaques. So lecanemab goes after these stages in the process. these earlier stages. Donanemab goes after the plaques themselves. So this is also slightly different mechanisms. We can't say that one actually works better because they both worked well. They both were effective in getting rid of amyloid. We can see this in different ways in these graphs. On lecanemab, about close to 70% of people got rid of all of their amyloid. In donanemab, it was about 80% cleared their amyloid after 76 weeks of treatment. So they did what they were supposed to do. We have a big review we wrote in our group, the CCNA, under Eric Smith, and you can access this in our CCNA website. I'm going to give you the website for that a little later in this talk, and I highly recommend you go to our website to get a lot more information. So we've reviewed all sorts of aspects of how effective these drugs were, the safety, and whether they should things to look for and things we need to know in the future, and more areas for future research. So this is our big Canadian article. So did they work? Well, this is the graph that got lecanemab released, published in the New England Journal, a leading journal, basically over 18 months. This is sort of you think of this as change from baseline. This is the deterioration. The blue line is people on the placebo. The yellow line, people on lecanemab, and overall people on lecanemab, those over 800 people, they progressed at a rate that was slower than the people on placebo. So if you're on lecanemab, the rate of progression was slower, about 27 to 30% slower. Um, then their function remained better. This is the decline in day-to-day function on placebo, and here's the decline on lecanemab. Again, the slope is different, and it's getting wider. This means lecanemab is doing something to prevent function from getting worse. But again, notice it's not a flat line. People's function didn't remain the way it was, and it certainly didn't improve. In the donanemab trials, it's very similar result. Um, they used a different measure of cognition and memory, but again, a 35% slowing of compared to placebo on people who were taking the donanemab. And this is another measure of thinking and cognition, 36% slowing compared to placebo. In other words, and the curves are diverging, and with longer follow-up, we see more and more difference. That means the disease is progressing more slowly in people who are treated. Now, this graph hides a lot of data, and this is a problem. Within this graph and this graph, there are no doubt people who did better than this and who actually stabilized. There are other people who didn't get much more of a benefit over placebo. So this is an overall summary of hundreds and hundreds of people. Another way of looking at what a drug is doing is not the difference in slope, but this difference, which is called time saved. This is the time to reach a further stage where people are getting worse, going from mild to moderate. Here's where the people on placebo hit that point. Here's where people on drug hit that point, and we can measure this as the time that's been added as mild dementia. And we can see in donanemab, they found about 5.5 months difference after 1.5 year trial. So it's buying people some time before they get to the next stage. Again, they're getting worse, but just not as quickly. And this was looked at in something called the Clinical Dementia Rating Scale, how long it took people to get to the next stage where they're going from mild to moderate or moderate to severe. And again, the people on placebo went more quickly into the next stage than people on drug, whether it was lecanemab here, donanemab here. So again, the drugs are doing something and they're having a benefit. So what was the reaction in the press? Well, a lot of debate. Um, this benefit, was it good enough to have these drugs released? These are disease modifying drugs, but they're not home runs. Were they worth the money? Because they're expensive. They're about $30,000 per patient per year. And you have to be treated probably a year or a year and a half. So if everybody with mild Alzheimer's disease or MCI in Canada got treated, that could be up to 1 million people. it could add $5 billion to our drug costs per year. That's about out of a total bill of $30 billion, we'd add $5 billion more. So it's not a cure. Is it worth the money? And this is something which the governments are now considering across the country. Um, there's something called the minimal clinically important difference. This is the difference in the scores that a doctor is probably going to notice. And this is a table with people with mild cognitive impairment or mild Alzheimer's. And these are sort of the differences we'd like to see between treatment drug and placebo to say they really made a difference. Well, when you look at the two drugs, their numbers are about half of what is needed to get over this bar to say, yeah, this is a difference that doctors would be aware of, families would be aware of. So this is a little uh, says they're not doing that much. The problem is there's a lot of variability within the groups. Some patients are doing quite well on the medications, others aren't deriving much benefit. And at this point, we unfortunately, as physicians, don't have a clear idea of who's going to reap the benefit if the drugs are released. And this is one of the problems. So why didn't they work better? Well, the amyloid PET scans got better in 70 or 80% of participants, but the patients still continued to get worse. Maybe the wrong forms of amyloid were targeted. Maybe the presence of amyloid has kick-started other brain problems that don't respond to the medications. Maybe pure Alzheimer's disease is rare and there are other brain problems that need to be treated, like blood flow problems, so-called vascular, or these other kinds of proteins we see as well. Or maybe there are subgroups. There's one subgroup where the decline is driven by non-amyloid mechanisms. So maybe you need a combination of multiple treatments that address different pieces of the pie. So we don't know the answer to this, and this is going to be an area of a lot of research over the coming years. Can we do better with multiple drugs or an additional drug or defining subgroups? We asked caregivers and patients what they thought of this data, and the feeling was a decision on treatment should be personal because I'm going to tell you about side effects in a minute. Um, some patients would want them, some would not, and obviously more will want them if they're paid for by RAMQ or OHIP or the government. And there were some concerns that treatments could prolong the moderate to severe stage of dementia. There were concerns about overinvestment in new expensive treatments. And there's problems already with accessing services and waiting times to see doctors and MRI scans. And what about patients in rural locations? Because these are intravenous medications. You need to go to an infusion center or hospital and get an injection once a month intravenously. So it might be that you have trouble getting access to these services if you live far from an urban area. Um, Lecanemab and donanemab have been released around the world in multiple places. This diagram is incomplete. Lecanemab in the blue, um, green shows lecanemab and donanemab. In Canada, lecanemab was approved by Health Canada a couple of months ago in November, and donanemab is being considered. Probably next month we'll know if Health Canada accepts it. And then there's red. Lecanemab was rejected in Australia, and there are a lot of countries we still don't know what they're going to do about these medications. So drug approval in Canada is multiple steps. Health Canada is the first big hurdle, and as I said, lecanemab was approved here in November, but then it goes to committees, Canadian Drug Agency for the rest of Canada, INES in Quebec. And a few weeks ago, I think before Christmas, INES said it was going to reject the dossier of lecanemab, and this means that RAMQ will almost certainly not cover lecanemab. We don't know about donanemab, the other drug, it hasn't been considered. But in Ontario, we don't know what the decision is going to be of the Canadian Drug Agency, but INES's decision basically is going to mean that RAMQ will not be covering lecanemab. Private insurance probably, and people could pay for it out of pocket, but again, the cost is we don't have the final cost in Canada. We can estimate $25,000 to $30,000. So this cost has to be negotiated. Then provinces have to decide if they're going to list it. So this is all going to happen over the next 12 to 18 months. So, in summary, in baseball terms, in my view, anti-amyloid disease-modifying drugs are a base hit. They're not a home run, but anecdotally, some patients did stabilize for a number of years when they took the medication. So, I feel I'd like to see these available, but I'd also like to have a better idea who is actually going to benefit. Now, we talk about, so there are many questions that have to still be answered. Is the benefit enough to warrant what will be quite an adaptation of the Canadian healthcare system? How long do you have to take them? Now they're talking about 18 months, but that could change in the next year or two. Do you have to redose or restart the medication years later? What about the MRI scan? It's hard to get an MRI scan anywhere in Canada. Right now, they do MRI scans 4 or 5 times in the first 6 months to follow people from getting complications that I'll talk about in a minute, called ARIA, amyloid-related imaging abnormality. So are so many MRI scans needed, and how are we going to get them? Can we target the MRIs to patients who are at higher risk? Can we use biomarkers to identify low-risk patients that don't need MRI scanning? And most important, can we figure out which patients are most likely to benefit from these drugs? So I don't have the answer to any of these questions yet. There are side effects. They usually occur in the first few months of using the drugs. One is an infusion reaction right after the injection. People can develop fever, chills, aches, nausea, but usually those are short-lived and you give them an injection of antihistamines and they go away. But up to a quarter of people treated at some point will get an infusion reaction. More important is this complication called ARIA, amyloid-related imaging abnormality. This means swelling or tiny bleeds in the brain related to treatment. This happens in about 1 out of 5 people. Now, most, up to 80%, don't get any symptoms. So we have to do the MRI scans every 2 months in the first 6 months so we don't miss these complications. Because when we see these, we don't give the next injection. We hold off for a month or two and wait for them to go away. Now, rarely there have been strokes or bleeding in the brain related to this ARIA response. And this is happening as the drug is working, pulling amyloid out of the brain. It causes the swelling or the tiny bleeds. Now, about 20% of people with this ARIA do get symptoms such as headaches or dizziness, and then you really have to hold the medication for a few months. It has been shown that people who have 2 copies of a gene called apolipoprotein E, the version 4, so ApoE4, if you have two copies of that, you have a higher risk of getting these side effects. So Health Canada has said that in Canada, people who are E4 shouldn't receive any anti-amyloid drug. So anyone who's going to go on drug is going to have this tested. Requires a blood test. And the MRI scan has to be done because if a person already has some tiny bleeds in the brain, and some people with Alzheimer's disease have this, if they're more than 4, then you shouldn't put them on this therapy. So we're going to need an MRI scan, ApoE testing, and someone to follow for these side effects for everyone who goes on to the drug. So ARIA, these amyloid-related imaging abnormalities, they look like this. They show swelling in the brain on an MRI scan. These tiny black dots, these are these microhemorrhages. So, as I mentioned, the problem is that we have to get MRI as an essential component of both treating with both of these drugs. So you have to get an MRI before you start to make sure there aren't microhemorrhages, and get one before the third, fifth, seventh, and 14th intravenous injections. That's for lecanemab, and donanemab is the same thing. So we'll have to make arrangements to have people go and get an MRI scan. MRI scans are hard to get in Canada, so this may become an issue, arranging with a radiologist to let them book the MRI scans for our patients. Now, there's a lot more information about these two medications. This is our CCNA website, www.ccna-ccnv, for the French version, .ca. And and it'll take you look for information on lecanemab, donanemab. We're updating this, and we answer a lot of the questions. So I highly recommend you go to this site for more information. Now, last point, not everyone responds as well. There are probably subgroups, and we have a lot more to learn about this, but this is extraordinarily important. For example, on lecanemab, if you can see males versus females, the more you're on the left side of this line, the more likely you are to get a benefit. Males got a lot more benefit than women. And some women aren't getting any benefit. So this is really important. And we have to have responder analyses to see, does everyone get the same slowing? Almost certainly no. We need to force the pharmaceutical companies and push them to give more and release more data on who actually benefited and who did not benefit. So this is another area where we simply need more information. The doctors need more information so that they can intelligently recommend you take the drug or don't take the drug. Another thing it's going to do is change the way we do diagnosis. Right now, anyone who comes to a memory clinic and has some blood tests and an MRI scan, they might be told, or no, you might be told your husband has Alzheimer's disease. Well, now we're going to move to calling it Alzheimer's syndrome because until you know about the amyloid, many people in the States are saying you shouldn't call it Alzheimer's disease unless there's amyloid in the brain. And this is confusing because when we call someone Alzheimer's in the clinic, maybe about a third of them do not have amyloid. It's a mimic. People look the same. There's no amyloid in the brain. If there's no amyloid, they're not going to benefit from anti-amyloid drugs. So this is true if people have a dementia or even if they have mild cognitive impairment. We need biomarkers to distinguish people with amyloid from people without amyloid. So what are these biomarkers? Well, is just showing this. Okay. We're shifting to a biomarker-based diagnostic approach because for these treatments, we need to know is there amyloid or not. We can do amyloid PET, and this is available, for example, at the MNI or even at the Jewish General. CSF, that's spinal fluid analysis. You take out a sample with a lumbar puncture, and all neurologists do this. It's not a big procedure. It takes about half an hour and the spinal fluid is sent for tests. And then serum, this is blood levels of biomarkers such as phospho-tau. And there are many blood biomarkers that are now coming available. So we're going to be using more and more of these biomarkers. It says AD related, Alzheimer's disease related, tau pathology. These show the tau, these show the amyloid. So serum and plasma blood tests, spinal fluid, amyloid PET. People are going to be needing these more and more in order to qualify for these drugs. Now, so has this been a paradigm shift? Well, it's made a big difference having access to anti-amyloid disease modifying therapy. Before, we had to tell patients there was no real way to slow the disease. Now we have meaningful therapy that can slow the disease. People used to think it was hopeless. Now there is hope. We're starting to see these important drugs coming. And from the medical side, medical students used to not be interested in dementia because there's not much to do. And now there's a lot more enthusiasm for careers. And we need a lot more people to treat dementia patients because there are more and more of them. So I think it's made a difference. But again, it's a single base hit, in my view, not a home run. Let's move on to prevention. Uh, I think you should think of your brain perhaps. Well, I've been watching football. Your brain is the quarterback of a football team. So, like the quarterback, the brain is under attack from the other side. It's under attack from risk factors such as aging, bad proteins like amyloid, those free radicals I showed, lack of blood flow, brain inflammation, other toxins like pollution. So your brain's under attack, but it's also being defended. You've got a front line, just like in football, and the front line is protecting your brain. We call these resilience factors. And we talk about brain reserve and cognitive reserve. and good brain habits. So these are the things we're going to talk about in the next few minutes. Now, the genes, what you inherit from your parents, make you more or less susceptible to attack. So the genes are like determining whether your front line protecting you is really good players or only medium players. So we can think of these risk factors, the attackers, and resilience factors, the protection, going on your whole life. For example, education is a resilience factor. The more years of education you get, the more you're building brain connections. In China, they showed that Alzheimer's disease was far more prevalent, occurred far more often in people who had less than 6 years education. Another lifelong thing you can do is physical activity. The better shape you're in, the better your brain is going to be for protecting and preventing the onslaught of the risk factors. And cognitive challenge, having a challenging job, doing interesting things, challenging yourself every day of your life, whether you're a teenager, an adult, or middle age or old age. And it's the balance between these two which is going to determine whether you get dementia. It determines your brain reserve and cognitive reserve, and also your neuronal damage and vascular. That means your blood flow problems, which fall under the risk factors. Um, what can you do to increase your cognitive reserve? Well, lifelong and long-term factors are important. We know people with higher socioeconomic status, higher income, more complex work, more education, people who are bilingual or multilingual, all those things build cognitive reserve, build your brain connections to help protect your brain from Alzheimer's disease. In the future, we may have a pill, some sort of pill that increases your cognitive reserve. This is speculation. Now we have nothing we can prescribe other than going back to school and having more money. So, Lancet Commission in Britain looked at what are the main risk factors, how much of Alzheimer's is preventable. They came up with a figure. This was in 2014. They added others in 2020. And basically, these are things that could be mitigated in early life, midlife, and late life. In early life is education. This is a big factor. So the more education you get, the better. In midlife, a leading factor was hearing loss. If you know anyone who has hearing loss, they should get hearing aids. That reduces their risk of brain illness and reduces their risk of dementia. And some of these are late life. I'm going to come back to the other factors in a moment. And every few years, they seem to add more factors. So this is the critical list that I'm talking about. Um, High cholesterol, depression, traumatic brain injury, and certainly you want to not let your kids go into boxing. Physical inactivity, very important. The vascular factors, diabetes, smoking, hypertension, obesity, these are bad for your heart and bad for your brain. Too much alcohol, other things, social isolation, air pollution, loss of vision, and getting less than 6 hours sleep a night. Altogether, the conclusion is probably close to half of the cases of dementia are potentially modifiable, but can we actually modify and prevent them by changing our lifestyle? And this is a look, there a lot of overlap with stroke. The same risk factors that decrease dementia can decrease stroke by an even greater amount, and also decrease depression. So the top four lifestyle things that decrease risk of all of these are getting moderate to high levels of physical activity. So everyone listening, if you're not physically active, not in a gym, not doing daily activities, start tomorrow. Cognitive stimulation of some sort, whether it's work, playing bridge, line dancing, or going to interesting lectures. Also, psychological things. People who have a purpose in life, who are not depressed, who are interested in what they're doing every day, that protects your brain. And unfortunately, alcohol. Now we're recommending drinking less than one drink a day. Um, Dementia may be the tip of a lifelong risk. We call this an exposome. People have had lifelong poverty and stress and air pollution, loneliness, all these things, lifelong and lifelong ill health, are under, here we're seeing the tip of the iceberg. These things are all lifelong factors that play a role in dementia. When we looked in Canada, this was a group within CCNA led by Manuel Montero Odasto in London, Ontario. And looking at the risk factors in Canada, physical activity showed up as a big factor in Canada. And look, it's hard when it's terrible weather like it is today in Toronto and Montreal, but we all have to be increasing our exercise to combat physical inactivity. Hearing loss, I already mentioned, midlife obesity, what goes along with physical activity. The US is a bit worse than us here. High blood pressure is still an important factor, and sleep disturbance. Everyone should be getting 7 or more hours of sleep a night. Are there dietary factors? Well, these are hard to study, but we believe there are. If you go on the Baycrest website, we have a brain health food guide. You can also get this through the CCNA with recommendations for that go along with the MIND diet, Mediterranean diet, which is low fat, low homocysteine, adding blueberries and other brightly colored fruit with flavonoids, adding antioxidants like orange juice, some coffee, cold water fish with omega fatty acids like salmon, and micronutrients. So if you get a brain diet, you're going to be helping protect your brain. I mentioned sleep already. I'm not going to say more. And then there are social and psychological things. For men, if you're unmarried in midlife, you have a higher risk of developing Alzheimer's and dementia. Other things, loneliness, lack of purpose, stress, depression, lack of social interactions, people who stay in their room and don't go out, all are related to dementia risk later on. So there are social things you can do that decrease your risk. Get out there, see your friends, see your family, and if you're a man, make sure you go out and get married. And floss. They're biofilms that collect on your gums every 24 hours. And if you don't floss, the biofilms have increasing amounts of what we call bacteria called P. gingivalis, which secretes some sort of toxin that gets into the brain. Flossing at least once a day prevents P. gingivalis and decreases your risk. The latest thing from last year is shingles vaccine. It was shown in a brilliant experiment that when they brought in a shingles vaccine in Wales, basically overnight, people's risk of Alzheimer's and dementia dropped by 15%. It's called a natural experiment showing that somehow herpes zoster is promoting dementia, and if you get the vaccination and prevent it, you're reducing dementia. So there's key remaining questions. If we educate people about lifestyle factors, will that result in them changing their behavior and reducing these modifiable risk factors? How about getting people into targeted lifestyle programs? Will that make a difference? How about targeted interventions like vaccination and medication and supplements? How far can we go in actually reducing, rather than theoretically reducing, the number of people getting dementia? In the future, biomarkers are going to help a lot. This is the same slide I showed together, but there are things you can measure in the blood, in the serum, in the plasma that are hints that someone is at higher risk of later getting dementia. So we may use biomarkers to help target who's at highest risk, including genetic risk. There have been some studies to try and look at what can be done to reduce the risk and help prevent dementia. This was the FINGERS study in Sweden and Finland. They took people who were overweight and they got them into weight control and diet and controlling their blood pressure and doing exercise and doing cognitive stimulation over the course of 2 years. And they found it had an impact. People who were on treatment, um, the controls showed a change in their executive function. The people who were on the intervention had a benefit in terms of their frontal lobe function, certain cognitive tests, tests of memory, and also things like cognitive decline, a lower risk for cognitive decline in people who did these lifestyle modification techniques. and lower risk of functional decline. So even 2 years of intervention of lifestyle made a difference. So right now we have something called Worldwide Fingers Network around the world, groups looking at prevention using different approaches. In Canada, the CCNA, my own group, has, we call it can thumbs up because there's fingers, so there's can thumbs up, there's US pointer, and so on. There's all these same finger jokes. In CCNA and Can Thumbs Up, we've developed an online education program which we're studying to see if by educating people, will they change their behavior? Will they change their nutrition, their cognitive engagement, their vascular health? And eventually, we hope if we can show this makes a difference, we hope that the Public Health Agency will roll this out for all Canadians. So it's still in the testing stage. And we're going to be testing at Baycrest in our Kimel Center for Brain Health different strategies, interventions such as medications, neuromodulation, stress control, dietary interventions to also try to reduce the risk. So in the future, I think there's going to be a prevention treatment cocktail. We'll be doing risk factor interventions like lifestyle changes, dietary interventions, and then probably a combination of medications given to people at risk to try and mitigate and lower their own risk. What we're doing right now, we've opened the Kimel Family Center for Brain Health at Baycrest, sort of the flagship for CCNA. And it's a center devoted to getting evidence-based programming. It's like a community center, and it is, we base a lot of it on the Cummings Center on Côte St. Catherine. Um, Programs that get people in, but also we're doing science. We're assessing their risk. We're giving them a personalized prescription, and we're tracking to see if we can change people's behavior over 6 months, 1 year, 2 years, and then show that lifestyle can be changed and it reduces their risk of dementia. So I'll jump over this. We have a whole bunch of programs oriented towards what people like and delivering programs in tune with evidence on dementia prevention embedded in research and clinical trials. And we're focusing on cognitive engagement, social connections, eating, mental and spiritual well-being, and physical activity. And I'm very excited about this. And we're using our CCNA Brain Health Pro Education program. We're just going to be starting this year added pharmacological interventions. Is it working? Well, we've got the first set of people who have gotten through 6 months and 12 months. What we found is of people who came in as clients, and now we're up to 600 people, about a third of them really weren't getting much physical activities. 100% of our people were eating not right. So poor brain healthy eating in 100%. Most people had insufficient cognitive engagement and weak social connections. So basically, we're filling a real need in older individuals who are coming to the center. And some people had a higher genetic risk. And what we can show even after 6 months is this is looking at physical activity. Basically, it's just where this line is, we've improved a little bit physical activity after 6 months of being in the center. We've improved the brain healthy eating a bit as well. Um, we've improved social connections. The loneliness scale has gone down a little bit. Um, and we've improved cognition a bit as well after 6 months. So these are complicated groups with lots of data, but the point is we're already seeing we're budging the the performance. And I hope if we keep people in for 12 months, 24 months, 3 years, will make a big difference in decreasing their risk. So, in conclusion, I think a new chapter has begun with disease modifying therapy for Alzheimer's and for dementia. There are going to be more medications, and please stay tuned. There's a lot of new knowledge about risk factors and potential prevention strategy. I consider that everybody's risk is probably about half genetic and half lifestyle and an environment. So, things you can do at any age to decrease your own risk. And prevention of dementia is now possible, but to an unknown degree. We need more trials and more studies, such as we're doing at Baycrest, there are real lifestyle changes that we can all implement in our lives to lower our own risk, and we can all start today. This is my group at Baycrest. I want to thank you for your attention. And on that, I'm going to stop sharing my screen and we can answer questions.
Let me get my video up here. Um, so we have one question here, Dr. Chertkow, about why the disease-modifying therapies are never or never seem to be aimed at those with moderate dementia. They always seem to be people in the very early stages.
I think that's a good question. Look, I think there are most of these disease modifying therapies are put forward by drug companies, and they're looking at where can they get the more bang for their buck in studies. And statistically, the likelihood of them making a difference is probably higher if they study people with mild disease, because when people are more advanced, the families are just, even if, say, they're someone's 20% better, families are likely to be unimpressed with the benefit. So by studying mild disease, they get more of an effect, a greater statistical effect, a greater, if they show a benefit, if they're effective, families are going to notice the benefit and they're more likely to be released, and families are more likely to pay if necessary for the medication. And unfortunately, what that means is when people get into a stage of moderate or severe dementia, the companies aren't really looking for disease modifying therapy at that stage. In a sense, they think that there's unlikely to be much of a benefit, and most trials are just not oriented towards those individuals, and that's the way it is. Now, does that mean someone with moderate dementia would not, with moderate Alzheimer's disease, would not have a benefit? The answer is we simply don't know, because if they don't do the study, we can't say if it would have worked or not. So it's a big gap.
Mhm. I just before I ask the next question, I just want to mention I saw that somebody had their hand up. Uh, so if you could put your question in the Q&A, you'll see at the bottom of your screen there's a Q&A box. We invite you to just type out your question in the Q&A, okay? So we have a question here about hearing loss. It says, is hearing loss a risk factor because of people restricting their socializing, or is it the hearing loss itself?
That's a very good question. We don't know. We think it's probably a combination, that it's something biological. If you're not stimulating the ears, you're not stimulating the brain. But it is a fact that people with hearing loss, if they don't get hearing aids, they retreat socially. They don't see their friends as much. They're not as socially active. And it's probably both of those factors.
Okay. There's a question here about primary progressive aphasia. Do amyloid reducing medications help with primary progressive aphasia, or are there other treatments?
That's a wonderful question. Um, this point, my reading of the literature, they really didn't concentrate on testing people with primary progressive aphasia. There's a chance that certain disease-modifying therapies may help, but probably not as much. At the present time, there's not much to offer people with primary progressive aphasia. However, my lab, in combination with labs at Johns Hopkins and University of Pennsylvania, we are trying neuromodulation with a helmet that gives electrical stimulation, very low dose electrical stimulation. It's called TDCS, transcranial direct current stimulation. We're funded by the NIH, which means they're very impressed that this is actually going to help. We're getting some very good results, not in everyone with primary progressive aphasia, but with some subjects. So if you have a relative with primary progressive aphasia, I would like to hear from you, and Karen and Molly will put you contact them. They'll put you through to my email because we're running studies right now at Cavendish Mall. People come in for about 10 sessions of 1 hour each. They do language exercises while they're wearing the helmet. And afterwards, we see a significant improvement that usually lasts a few months. In some of our subjects, it's been dramatic enough. They went and purchased the machine. The machines are available for about $800, as low as that. So this is the one therapy that has been shown to be effective. So I plead with you, anyone with any form of primary progressive aphasia, contact Karen, contact Molly. They'll put you
With
through
the
to my
information.
email. And we're running the study in Montreal as well as Toronto. So now is
Well,
the
the good
time.
news is the person who asked that question has commented that that their loved one is already part of the study. So
Okay, so that's
good.
good if you're part of
Yeah.
the study. And again, I should add that we are also starting studies to see if we can help people with memory loss, with Alzheimer's disease or MCI. So if you're interested in being part of a research study, there's very little downside other than you have to drive 10 times to Cavendish Mall. Um, but other than that, other than the time commitment, there's no real adverse events, and we're very eager to get more people in for our tests to see if we can help them.
So another question we have here, and before you answer the question, I'm going to suggest that the person who asked it give a call to the office and speak with the counselor about your specific person in your specific situation. But the question is about getting somebody who's in the early stages, who's starting to show forgetfulness to the doctor when they're
So about getting them to the doctor when they're having symptoms of forgetfulness.
is not really acknowledging or aware of their forgetfulness.
Yeah.
And so they're
This is
not
a
really willing to be screened.
look, we know that dementia, such as Alzheimer's, is not just a problem with memory. There are emotional changes. People can become apathetic and depressed and not want to do anything to help themselves. There are personality changes. People can be more argumentative and paranoid. And there's also loss of insight. People are simply not aware of their own changes in thinking and planning. The family members are aware. The person with the illness is less aware. So what do you do? It's a time you have to be very gentle and build on the trust that the person has with family members and say, we're worried about you. We need you to get to your doctor. We're going to come with you because you don't know that it's Alzheimer's disease. Sometimes there are reversible factors, problems with thyroid, problems with kidney function. Simple blood tests might show an abnormality. Remember I had one lady come, the family finally got her to come to the doctor, and she had a frontal lobe brain tumor, that a benign brain tumor that had to be removed. So you can't make the assumption there's nothing to do. And this is a time for a family member to use their most diplomatic means of working with the patient and saying, look, we're concerned about you. We want to go with you to your doctor to see what help you can get.
And listen, I strongly suggest whoever asked that question to give us a call and talk it out with the counselor because we'll find some creative ways to get things going in the right direction. So another question we have is about lifestyle interventions as opposed to reducing risk before having dementia or focusing pharmaceutical interventions after. Is there any evidence about lifestyle changes while a person has dementia that improves prognosis?
Yeah, that's a very good question. We don't have much evidence. Um, for example, switching to a better diet that's good for your brain, is that going to slow down progression of Alzheimer's when someone has Alzheimer's dementia? No one has really done that study. Um, these are prevention strategies. We believe they're going to be most effective if carried out early on. But it's the very similar situation to where we were with heart disease, 50 years ago. I remember a man in the coronary care unit after his first heart attack, calling me over in the middle of the night and saying, "Doctor, I've decided I'm giving up eggs." And he had a heart attack. Would giving up eggs, he was worried about his cholesterol. Now, we now believe that yes, you should continue to treat cholesterol even after a heart attack. It's not too late. Same thing, we believe it's never too late to start exercising. So I recommend exercise and social engagement and cognitive activities for people with mild cognitive impairment, with mild dementia, even though we think the biggest bang for the buck, the biggest impact is as prevention years earlier.
So can I also jump in a little bit with a thought on that, Dr. Chertkow? You know, there are lots of lifestyle changes that can improve quality of life and emotional health, whether or not they improve cognition, right? So I think organizations like ours at Alzheimer Group, we're not trying to treat the cognitive changes brought by Alzheimer's disease, but everyone who improves their social and emotional lives while living with the disease is going to experience a better quality of life, no matter what stage their cognitive
Yeah.
health is at. And so I think that it's important to remember that there's a lot we can do, and quality of life is not based only on your cognition.
I couldn't agree more. I think that's absolutely correct. And look, people with Alzheimer's and MCI are lonely, they're depressed, they're isolated, and those are factors that can be improved by getting in a group and being with other people and getting out of the house. So absolutely, I think a group like the AGI can play a really big role in trying to improve quality of life.
Yeah. So we have, I'm not sure this is much more a question or a comment, but I'll share it with you and you can share your thoughts on it. This is a person who is living with type 1 diabetes and has been for 52 years, and is talking about a comparison of treatment costs, benefit of, like the benefit of 52 years on insulin improvement versus 5 months of benefit of going on these expensive new medications for Alzheimer's. Um,
Well,
that's
let me say this. It's been pretty clearly shown that the most effective thing you can do to prevent or slow Alzheimer's disease is to treat the vascular component, high blood pressure, diabetes, cholesterol, stopping smoking. These are far and away the most effective weapons we have in prevention and in treatment. So I'm often telling people with mild memory loss, look, your diabetes should be under better control, your blood pressure should be under better control. Now, uh, uh, it's important to realize that it's easy to say this, but many older people with high blood pressure do not have it controlled. So if you know someone with high blood pressure, get them to their doctor. If they don't have a doctor, get them to the CLSC and get some sort of therapeutic alliance and therapists to work on those because those are hugely important, whether you have normal memory or mild memory loss or dementia.
I'll also say I think looking at new medications for dementia as kind of um, a cost benefit analysis is a little bit difficult because very rarely does a disease get sort of cured in one shot, right? Like with diabetes, you take insulin, your diabetes is under control. It's unlikely that a cure for Alzheimer's is just going to appear like that. But, I've been working in this field for almost 20 years, and this is the first time something is slowing down the progression of the disease at all. And so, my thought is if we don't give people the opportunity in large numbers to be on these kinds of medications, we're not going to learn what it is that they're doing that we can build upon. I don't know if that's something that resonates with you, Dr. Chertko, or is that my layperson's like understanding of how these
Yeah.
things?
No, I think so. The question was about, if I understand it, the question was actually about what's all this talk about this expensive drug that just slows things down. look
Right.
at
As
insulin.
opposed to something like insulin that,
Sure. So let me be clear on this. If we're going back to our baseball analogy, the discovery of insulin for diabetes, that was a home run.
right.
Overnight it transformed treatment of diabetes from a death sentence into a lifelong disease that, it doesn't cure diabetes, but it totally changed these. What is another home run? Every day when you have put salt on your egg, you're giving yourself a little bit of iodine to prevent goiter. And this costs about 11 cents per person per year to add iodine to salt. So, have you ever seen anyone with goiter? I don't think I have. It's totally prevented by this very inexpensive adding. So this is what we want for Alzheimer's, something like iodine or something like insulin for diabetes. We want the home run, and that's what people are looking for. And uh, unfortunately, the brain is proving harder to treat, and Alzheimer's is proving much more complicated. And I agree with you. I think we're going to get there. We might get there incrementally, step by step, rather than one breakthrough medication. So I think a first step is that. It's a first step, first meaningful step in a right direction, but certainly not the last step.
So we have another question here. As years go by and research and teaching keeps improving, what are your thoughts and opinions regarding family physicians' basic knowledge, insight, and proactiveness for better screening and treatment of dementia?
Yeah, I think the job of being a family doctor is huge and complicated, and each step of progress is another stress on them. And look, I like very much what Howard Bergman and others have been developing in Quebec, where it's a family practice group where they're often having one family doctor who's more interested in aging and memory, and having a infirmière pivot, a nurse prac, a case manager to help people, because family doctors are simply overwhelmed in trying to figure out another illness. Now, the other thing is about screening for a family doctor is something very definite. Is a test you do in everybody to look for something where you're going to make a difference. And it hasn't been shown that screening for memory loss, screening for Alzheimer's is going to make a big difference. So, from a family doctor point of view, if people come in with a memory complaint, they're being trained now in what we call case finding and in responding, testing memory, ordering some blood tests, and then maybe passing the person off to a specialist. So that's not quite screening. But with the new medications, it's sort of up the ante. Taking care of these people is complicated, the diagnosis is more complicated, and family doctors may not have access to PET or spinal fluid. So for the present time, although we'd like to see this be in the realm of family practice. Prevention is family practice, but anti-amyloid therapy, even in Canada, unfortunately, is largely going to stay with the specialists for the time being. As far as family physicians' basic knowledge and insight, I think they're an extremely hardworking group. Unfortunately, family doctors there aren't enough of, and that's the fault of the Quebec government and the Ontario government in very poor planning, as we all know. And they're being overwhelmed with paperwork these days. And hopefully, AI is going to take away some of this burden so they have more time to spend with their patients to give them the attention they need.
So we have a question here about using lithium to treat Alzheimer's, which is not something I've heard of before.
Well, thank you. The lithium story is very interesting. People with bipolar illness take lithium as a therapy, but it's about 300 milligrams each pill. You take that 2 or 3 times a day. But it appears that lithium in very low doses blocks the tau protein, may prevent phosphorylated tau and neurofibrillary tangles. So it's been looked at as a treatment. That didn't go very well, but it may have a role in prevention because it appears that parts of the world where there's not enough lithium in the ground and not enough lithium in the water, that those areas have a higher rate of Alzheimer's disease. So there may be a role for microdose lithium in prevention. The world expert on microdose lithium is probably Claudio Cuello at McGill University. He's been working with animal research on this area, and this is an area that we're very interested in doing trials with this in terms of dementia prevention. So it's a very interesting and important area.
So we have a question here again about people who are more in the moderate stage of the disease. What determines when the Exelon patch is no longer effective, and what are the risks of stopping it?
So I did talk a bit about symptomatic therapy of Alzheimer's and mixed dementia, for which you've had the medications for 20 or 30 years, and something called cholinesterase inhibitors that try to increase the level of acetylcholine. There are three related medications, donepezil, galantamine, and rivastigmine. And rivastigmine is available as a patch you put on the skin to avoid side effects like stomach upset, nausea, loss of appetite. So, it's recommended that everyone be tried on at least one of these, and if they have side effects, switch to another one. So the rivastigmine patch has advantages over the others because it doesn't upset the stomach. So what we see is a modest improvement in thinking and cognition, people becoming more interactive and more available to their families. It doesn't prevent someone from getting worse. People, they may start on it when they have mild Alzheimer's, and it goes on a few years later to moderate Alzheimer's and then severe Alzheimer's. And there is a tendency in medicine, if someone's on a medication, to leave them on. And at that point, it may not be making any difference. And unfortunately, as a physician, you don't really know if the drug is doing any benefit. And I have a lot of patients, I say to the family, we're going to stop the patch, and sometimes we go down to a lower dose patch for a month or just stop the patch altogether. I say to the family, let's see if you notice any difference in terms of a person being less active, less interested, less interactive, more confused. And usually the family say, we stopped the patch for a month, for 2 months, we notice no difference. So then you say, well, wasn't doing anything, we leave it off. Sometimes, and this is the problem, occasionally the families phone up a week later and say, my father's a lot worse off the patch. Now he's more confused. And I say, well, okay, go back on the patch. And that's the only way that you know if it's doing anything. So the feeling is that probably as people become severe, that all of these medications they're on should be one by one taken off. But you have to have an interested physician who's going to say, look, I doubt the medication's doing anything. Let's stop it, and we'll reevaluate in 2 or 3 weeks. And now we'll stop this medication. And often geriatricians stop 8 out of 10 medications that an older person is on when they go into a long-term care institution. So that's the approach. Judicious, working with the doctor to try stopping these medications.
So we have a question here about the risk factors of high blood pressure or diabetes. Are they still considered risk factors if the person is medicated and it's under control?
Yeah, so this is a tough one because um, obviously high blood pressure and diabetes that are properly treated, and so that you've got normal blood pressure, normal blood sugar, that's the best you can hope for. You never know when you look at the MRI scan and you see changes in blood flow, and you say, okay, the person has a history of high blood pressure. And sometimes they'll say, well, yeah, but it's been treated. So you don't know, there's damage more than normal? Is that from the years when it wasn't treated adequately, or maybe times at night that is still high, or is there something going on in the blood vessels despite adequate treatment? So I think that obviously the goal is to treat blood pressure and blood sugar properly. Um, does that lower the risk to nothing? I can't really say because people still appear to be at somewhat higher risk than other people.
Thank you. So we seem to be at the end of our questions. I do have one question that was sent in about moving a person into alternate living situations and breaking the news. I'm going to suggest that that's more of a talk to your AGI counselor kind of question. So for whoever, I don't know who sent it in, but whoever sent it in, give us a call. We'll make a counseling session. It's free. We'll talk about that in detail for a whole hour. Okay. So thank you very much, Dr. Chertkow. That was really, really informative and interesting. I'm amazed how year after year there really is progress. There's change. There's new things on the horizons. There's new things that have happened over the year. Um, after working here for almost 20 years, it's amazing how much things have changed, how far we've come. I think sometimes there's this idea that Alzheimer research is stagnant. And, not having found a cure doesn't mean that we're in the same place that we were 20 years ago, right? And I think that for me, anyway, coming to these conferences every year helps me to remember that, helps me to keep the hope of that side of things going too. So thank you.
Thank you for having me.
All right. So take care, everybody. Uh, we thank you for coming. We thank you for your time, your attention. If you have any questions or comments that you want to send AGI afterwards, you're welcome to do so. Yeah, and don't forget to give us a call if you are looking for any services, counseling services for people living with dementia. We are here to support you. All right. Thank you very much. Bye-bye.
Bye-bye.